Good afternoon, everybody. We have a actually very nice talk today. Will be presented by. Actually, it is a debate on the. Is there a role for a new generation of AOM for preventing diabetes? In the positive points, we have a speaker, Dr. Saptarsi Bhattacharya, and for effects maybe require or not require in the negative side, Dr. Jasit Vasir. And the expert review, we have Sir Dr. Makar sir here. And with the starting of this, we'll just introduce Dr. Saptarsi Bhattacharya. He's MD, DM, FSE, Specialty Certificate, RCP UK. He is Senior Consultant Endocrinology, Indraprasth Apollo Hospital, Delhi. He is also member Educating Working Group, International Society of Endocrinology. He is ex-secretary, South Asian Federation of Endocrine Society. He is also executive committee member, Endocrine Society of India. He is also Honorable Secretary, Endocrine Society of Delhi, ex-president, Society for Promotion of Education in Endocrinology and Diabetes, and he has more than 95 publications in Index Journal. A warm welcome, Dr. Saptarsi, and will please. Yes.
So we have 10 minutes for both the speakers, and we have 2 minutes for rebuttal each. And then I am supposed to give my expert review. I don't know how much of expert is there, but review will be there definitely. And Jasjeet is laughing because he knows that I can't do anything about it. So, anyways, let's have Saptarishi going first.
Thank you, Chairperson. Thank you, Dr. Makkar. So, I am going to talk on. Can you have the slides, please? Yeah. Is there a role of new generation anti-obesity medicines for preventing diabetes? So, I am going to speak in favor of the motion, and Dr. Makkar will lastly give his concluding remarks, and I have Dr. Jasjit Wazir who is going to speak against the motion, but many of you might be in the morning session where he was actually moderating the session on tirzepatide, and he did a wonderful job and spoke so many things in favor of tirzepatide, and I think he is just disagreeing to disagree for in this debate. So obviously we'll go just step by step. So obesity and diabetes, I think we all know that the estimates of the prevalence of diabetes, its estimated prevalence is going up like skyrocketing. And all
Saptarishi, just can we set the timer at 10 minutes? It's already 14, 15 minutes.
I'll finish at 4.
Yeah. We we have to change the timer.
Yeah. Yeah.
10 minutes. Now 9.5.
So, and if you look into this World Obesity Federation data, so there's a huge contribution of BMI in non-communicable deaths, and so you can see that almost in 2019 of almost 10% diabetes almost contributed to 42% of the causes of non-communicable death, and also at the same time uh, it contributes to the quality of life deterioration. And the very alarming thing is that even in children, the rates of type 2 diabetes, so in our when we are doing MBBS and all, so we all thought that children it's type 1, adults it's type 2. Even there is increasing prevalence of obesity as well as diabetes in our in 8 years, 10 years, 12 years. We see children who have acanthosis, and obesity has multiple negative effects. So research just not a cosmetic for cosmetic purpose. We are treating obesity. It has multiple negative effects, and we will be talking about diabetes specifically. That is a focus area today. And so, in fact, if somebody develops diabetes, as far as Dr. DeFronzo, so almost the 70 to 80% of the beta cell insulin secretory capacity is already gone. So, if somebody is having diabetes, so that is it's not something that he has started having a problem today. That was there for years. and that has reached a critical level and is manifesting today. And we actually have this window where we can prevent it. So because a diagnosis of diabetes, if you look into it metabolically, so it's already an advanced state of metabolic dysfunction. So if you are planning to start, it's pre-diabetes, it's nothing, it's obesity, it's nothing. So there are obviously the rates of progression from obesity to diabetes, that's very high, and obesity has multiple pathophysiological connections. I won't go into the details, but again, the fat tissue is it's a source of low grade chronic inflammation. So if you are so there is the inflammation hypothesis that obesity can contribute to the risk of development of diabetes through inflammation. There's also the adipokine hypothesis. So it's obese adipose tissue is one of the largest endocrine organs in our body actually. So it secretes multiple hormones. They are called adipokine. They also drive the development of diabetes. And also we know the lipid overflow hypothesis, where we know that initially the white adipose tissue is supposed to be good protective, but once with chronic calorie excess, if the adipose tissue store gets saturated, that adipose tissue spills up into liver and other viscera including pancreas, and that contributes to diabetes. And that has been the guiding principle for the twin cycle hypothesis. We all know that if you can cause weight loss, you can actually prevent reverse diabetes. So this is something where again mainly by lifestyle, but also we will have a look how the medicines can work. So, how much weight loss is needed to prevent obesity related complications? So, approximately if you are losing around 3 to 10% of body weight, so that there it can be it's enough to prevent diabetes. So, approximately you can take 10%. And if you are losing 10, 15 or 20% of body weight, you can actually go into diabetes remission. But having said that, diabetes remission will be temporary if there is a lifestyle reversal. So as long as you are that is the hardest part. So it's not that the lifestyle interventions will not be working, but to maintain that is a real challenge which we all face. And there are multiple ways by which obesity actually prevents the development of diabetes. Again, not going to go into the details of that. So what I told earlier, that this process, this phase of uh, there is a long phase, latent phase, where the glucose levels are borderline high. The insulin, there is initially insulin resistance, the insulin levels go up. After that, the insulin levels will go down. So the person, when loses a critical amount of beta cell secretory capacity, will convert convert into full blown diabetes. And if we look into diabetes rate among normal weight versus overweight versus obese, so almost it's 4 times higher. So if you look into the normal rate of conversion of diabetes, so for a normoglycemic percent it's 10%, for an overweight person it's 20%, and for obesity it's like 40%. And obesity and probability of diabetes, so even so obese individuals are almost 4 to 5 times more likely to have diabetes than normal age individuals. So obesity provides us an opportunity to prevent identify those group of people who are at risk of development of diabetes. And there are multiple lifestyle intervention trial. It does work, but again, Dr. Jasjeet will agree that it's very difficult to maintain lifestyle, obviously. So it sounds good that you are dieting, exercising, but again, if you are dieting, unless you are really cutting down your calories, so the weight loss is not that much. If you are doing aerobic exercise, hardly there is a weight loss of 2 to 3 kg, so it will be less than 1 to 2% weight loss. If you are doing strength training, in fact, there is some weight gain also. So maybe it's because of gaining of lean mass, but actually exercise isolatedly, it does not cause weight loss. Exercise and diet in combination, and the exercise duration should be at least, so whatever we recommend 150 hours per week, that is 150 minutes per week, that is actually not enough. So that is just able to maintain the weight. Even those who are obese actually tend to gain weight with that value of that amount of exercise. And there are other pharmacological intervention trials also, which includes metformin. So if you see, the weight loss in these trials is around 3 to 4% maximum. Some of them have not caused weight loss, and the risk reduction in diabetes is around 30 to 40%. So this is okay, but we have newer opportunities like this whole group of molecules which have been the umbrella term for that is nutrient stimulated hormone based therapies, and we see the weight loss, they are in various stages of development, and what we see, the average weight loss is between 15 to 25%. So there is a triple agonist retatrutide, which causes 25% weight loss, equivalent to almost bariatric surgery. Tirzepatide, it's causing 20 to 20% of weight loss, and on follow-up, it actually the weight loss increased to 26%. So it kept on going down, and we have also semaglutide specific dedicated obesity trial, select trial, we see there is a 73% risk reduction. So almost double the rate of risk reduction which we for prevention of diabetes, which we see with conventional therapy. If we look into again tirzepatide, this is a surmount trial data, and I have deliberately included that study where there has been an off period also for from 176, this is 176 weeks, so the person kept on losing weight 20 to 24%, and then when they were off tirzepatide from 176 to 193, there is slight rebound. So this is something which is quite encouraging. So it not only keeps on causing weight loss, it also the rebounds. There are some trials there is which show that there is a 9 to 10% weight loss, but that discontinuation was done earlier. If you go for a slightly longer period of around 3 hours, the rebound is even less. So incidence of type 2 diabetes actually, so it's drastically low with tirzepatide, the newer agent. And if you look into this, type 2 diabetes, pre-diabetes, normal glycemia. So even if you had seen the earlier trials, so there were around 14 percent, 15% cases of diabetes which developed during the trial. So here you hardly have less than 1% chance of developing diabetes, and almost so this is not only this is not pre-diabetes we are talking about. So progression to normoglycemia. So those who lose around say 10, 15 or 20% of body weight, they are normoglycemic. They are not even pre-diabetic. So I think there is a time. This is a time to act. Theoretically, yes, lifestyle changes are good, but we need to treat obesity as a chronic disease, and we should offer the best of treatments to our patients so that they do not think that okay, I have developed diabetes today, so this is the beginning. So they need to understand it's a, if once you have diabetes, it is a long and chronic disease which requires multiple treatment, so you actually have to prevent it, and we have the agents to do that. Over to the chairpersons for the
Thank you,
proceedings.
Dr. Supratik. And now we'll have Dr. Jaspreet Wazir speaking against the topic.
So that was amazing, and I anticipated your slides so well without seeing your slides that I have put specific remarks of what you've just presented in my slides. And I really thank you for giving me this opportunity of a rebuttal on AOMs and prevention of diabetes. I'll be talking against it. Well, honest disclosure, a few sessions back, I was moderating tirzepatide, and we were talking about it being one of the greatest wonders of weight loss on planet Earth. But here I'm talking about uh, against using AOMs for prevention of diabetes. So, okay. So Saptrishi has done his job, so I'll be talking against it. So let's have a I need quick answers because I just have 10 minutes for this. Can diabetes be prevented or delayed All those with prevention, raise your hands. All those delayed. So we have kind of you're delayed. Okay. So we have kind of a majority in diabetes can be delayed. First point, it can't be prevented actually. Will you prescribe AOMs, anti-obesity medications to in capitals, all your patients with pre-diabetes? That's what Saptarishi just said. He laid a trap for himself. All those who will in all their patients. Do I need to go into the next slide? Yeah, it wasn't. Anti-obesity drugs, prevention of diabetes was the topic. So technically, I have already won the debate, but I will complete it because Saptrishi and me are very good friends. We need to come out combined winners. So my disclosure as a passion of my profession, I believe in preventive health, wellness, health, and longevity, which will reflect in this particular presentation. So I did prepare very well for the fight and had to think about the strategy. A lot of the points Saptarishi has already presented, which I'll be using. Yes, you prevent diabetes. It's a big winner, and a patient feels like a hero because you've prevented a disease from happening. There's nothing better in medicine than prevention of a disease. We all agree on that. However, we've been hearing this concept forever that genetics plays a big role in non-communicable diseases. We all agree and accept the fact that genetics cannot be changed and hence pre-diabetes cannot be prevented. It's like a ticking time bomb which can burst and you have environment pulling the trigger and that's where manifest diabetes happens. By weight loss and lifestyle changes, we're actually delaying the onset of diabetes. There are some answers which I may not have, but more of a conceptual scientific note. I present these slides. We all, Saptrishi talked about Diffronzo's octet. So this octet runs on genetics and environment and epigenetics all put together. And it involves all of these organs where weight loss can benefit in most of them and these medications act on some of the pathophysiological defects involved in the final causation of diabetes. Accepted, done and dusted, and we move on. So the ADA 2024, this is the headline. So can the question you've all answered, can we really prevent diabetes forever? The words are clearly put. We all accept and are shaking our heads and saying, no, it cannot be. However, it can be delayed as long as the weight loss is maintained. Agreed, right? So what are the ways forward? Nutrition, weight loss, fitness. Now, Saptrishi in his presentation said that you do weight training, you gain weight. Everybody was nodding. They said, yes, we gain weight, but however, that weight gain is muscle mass. So I would love everybody to gain weight by resistance training because muscle health is one part where, yes, genetics, we may have smaller muscle mass. However, that's one of the integral parts of the triad or the octet or whatever of causation of diabetes. And as we build the muscles, we are actually, even without weight loss, just with fitness, there is good scientific data about prevention of diabetes. And the only intervention in this whole discussion which can provide longevity is fitness. I'll present that data also. So the core area about prevention of diabetes, the center is about weight loss and the number hovers somewhere around 5 to 7%. This is based on the diabetes prevention trials. Not what I feel, based on the diabetes prevention trials, 5 to 7%. Now, Saptrishi said, tirzepatide 22%, you add lifestyle to that, it gives you 26%. We have retatrutide giving 28%. Great. But for prevention of diabetes, it requires a smaller sustained effort, which can easily be attained with a lifestyle change. So my prescription to start off with would be a easy to do, permissive, not a restrictive. Don't do this, don't eat that. Very easily possible. And when you practice in your real life, you will realize that patients do follow it. Not forever, weight regain does happen, we are open to discuss about that. And the fitness must include aerobic and resistance training. We all agree about that. The second part is extremely important when we talk about prevention of diabetes, wellness, and longevity. Now, he's already covered this. I did think it's important to give the potency of GLP-1 based therapies. This is a meta-analysis showing that these drugs are very effective, dose dependent. The longer you give it, it works well. He talked about tirzepatide. This is the data. I won't go into the details of that. However, this is where what he did not present, that once you stop the drug, what happens? All the weight comes back. And with the weight, the likelihood of rest of the cardiovascular risk, the diabetes and all may come back. We don't have trials really measuring that, but it's likely to come back. So moral of the story, you need to give these drugs long term or lifelong. In my practice, I use the word long term because patients get turned off by the fact when you tell them zindagi bhar ye dawai leni hai. We all agree on that. So this is the first pitfall where you fell into. The ICMR INDIAB study, now this is the map of pre-diabetes in India. That means, according to my dear friend, this is the kind of population to whom we need to give the anti-obesity medication for prevention of diabetes. Okay, I'll take it well. However, the annual rate of conversion of pre-diabetes to diabetes, 5 to 10%. So every year we need to be more and more intensive to reduce the overall prevalence or the impact of diabetes. So pre-diabetes is more like population-based approach for better health of a society or of a country. Again, a place where he fell short. Now, this is so many questions I've already raised. I'll raise another one. We have a large percentage of patients with lean diabetes, and the same would hold true with lean pre-diabetes. Now, the topic of discussion is, let's take a arbit percentage of maybe 10%, 20% of patients are not obese by the BMI criteria. What about them? So are we going to deny them anti-obesity medication because we say they are so potent in reducing the fat mass? We're talking about BMI, using BMI as a cutoff for deciding the anti-obesity medication. So another place where those pre-diabetics who are the so-called lean by BMI are denied the benefit by not prescribing these drugs to them. And in one of the slides you were presenting, you said those who have a normal BMI have a 10% chance. That's not a zero. Fine. So this is the population where we are missing out again a trap. Now this is Saptarishi telling his patient, you don't have a disease, but prevention of it for this disease, I recommend you to take the medication lifelong. What would be, we've talked about very good science that he presented, which I accepted, I included in my presentation. However, what is the most common response of a patient to this? Doctor, I'm not going to take it. And then it's a push, pull, a shove. And finally, when they would, okay, accept the fact that yes, it's important to prevent diabetes, to lose weight, they accept the medication. With insulin resistance, I accept the fact till weight loss happens, we prevent diabetes. But what about the beta cell dysfunction? There's so much of genetics involved in that. Is that also going to be halted? That's one point. I see some nods that they agree with me. Some are very muted. I don't have an answer to that. Maybe in the rebuttal, we could have an answer on what would have the beta cell when you lose weight over a long period of time. Would they still decline, but at a lesser rate? I accept with that. Very important thing. If out of pocket expenditure is happening, this is the kind of burden being put on a patient on anti-obesity medication, and you just spend $1 on lifestyle changes, very well respecting the fact the limitations of lifestyle change in sustenance and weight regain, but not to forget those who are fit can prevent diabetes and live longer despite the fact they have not lost more than 5% of weight. I am very sure of what I just said. The last few slides, this I think I'll skip. This is the impact of fit. Well, just closing. This is the last hurdle which he has to cross. Patient safety issues. There's a list of things. You prescribe the drug for prevention of disease, which has not happened. You tell the patient it's going to be this expensive. You tell the patient you got to take this drug lifetime, and you are mandated to give them a list of these complications which are happening, can happen, or potentially could be there, including a cancer. See what happens there. So my suggestions, which would be put to the test of the expert, whom I tried my best to bribe, but I couldn't bribe him to side with me, are Saptrishi and me take a middle path on this and come to an agreement on the suggestions which I'm giving on this legal paper, which should be signed by everybody present here. We can offer anti-obesity medications to people with a BMI more than 28, age less than 40, at least one family member with a history of type 2 diabetes, history of gestational diabetes. Now, some of these are taken from the diabetes prevention trials. They were the patients who were offered metformin. They were the highest risk patients, taking leads from there. Abdominal obesity. Now, this is very important. When we talk about failure of lifestyles, those on a lifestyle change have gained more than 10% of weight or not able to lose weight, not achieving 5% at 3 months, at least two attempts, failed attempts of lifestyle changes, etc., etc. Basically, high risk patients with a fasting glucose more than 110, A1C less than 6%. And once we accept all of these, I would put the entire decision of a victory onto our expert judge here. And I thank all of you for patiently interacting and listening to me. Okay.
It was obviously full of entertainment, and uh, so it was fun to listen to. But again, say, so I am not professing, or everybody in this hall knows that, like most other conditions, including diabetes and obesity, so this has to be individualized. The topic for this debate is not using tirzepatide or semaglutide like a vaccination or a community prevention. So the topic is, if a patient comes to you, say with a BMI of 27, who has NAFLD or MSLD, whatever you want to call it, and who might or might not be having family history of diabetes, is starting to develop slight osteoarthritis. So, and maybe having a family history of CAD. So, would you, and if the patient wants to discuss the option of these newer anti-obesity medicines, how many of you will tell, no, I won't give it? Please raise your hand. So, Dr. Wazir, do
No,
I?
you change the narrative now.
So
This is unfair. He's changed the narrative now.
So,
But yeah, we both are absolutely no. No rebuttal needed because we both reflect
so I
that we
hand
need
it over
to
to our
individualize
respected judge.
the prevention of diabetes.
So I think very good presentations from both, but I think this is my personal view. Both of them actually deviated from the main, topic that we wanted to come up. The topic is there any role of newer anti-obesity medications in prevention of diabetes? So Jasjeet, made it, will you use? Now, will you use is the second thing. First thing is, is there a role? I want to use or not is a different story, you know. So he made it something like you are going to commit a crime if you are going to use.
Yeah.
And now Saptrishi again, will you not use? Again, there is a question. It's a very, very kind of tough decision that you are. Important thing is now we are living in an era where we are getting newer anti-obesity medications, and we have to see whether they can be important in playing a role in prevention of diabetes, and is there a data? That is most important thing that we should look at. So I will briefly take you through few studies where I will show you that there is definitely a role of anti-obesity medication in prevention of diabetes, and it is documented. And it is not something new. It has been documented for so many years. Uh, how does it work? Okay. This is working or no?
The lower one. Low.
Okay. So I have no disclosures in this. Now, first thing is we look at the what are the major risk factors for pre-diabetes. And two major modifiable risk factors are obesity and decreased physical activity. And that is where what we can change. Rest, nothing that we can change. So genetics is fine, we are predisposed, still we can change this. There are a number of lifestyle intervention trials which showed that we can have prevention of diabetes, we can reduce the risk of developing diabetes significantly. Important thing is modest weight reduction is good enough, and which Jasjeet highlighted very nicely. Now, question is there a role? Now we know that weight reduction can help you in prevention of diabetes. So it is very logical that we can look at anti-obesity medications as one of the facilitators for prevention of diabetes. And we know if you lose 5 to 10%, you will prevent diabetes. And if you are losing more than 15%, maybe you will reverse diabetes also in existing people. First data came from Orlistat. Xantos trial, 4 years follow-up, only 4.5% reduction in weight and 37% reduction in the risk of diabetes. So this is not something which new that we are looking at. Prevention of diabetes is documented with anti-obesity medications long time back. Then we had liraglutide studies, and liraglutide pre-diabetes study again showed that there is significant reduction in the risk of developing diabetes as compared to placebo when you are using liraglutide 3 milligrams for weight reduction. Similarly, we have data from multiple drugs. Lorcaserin, though it is no more in use, we had Bloom diabetes and Blossom trials, significant reduction in the risk of developing pre-diabetes in people who had been treated with, Lorcaserin. 3 years follow-up is there. And there was 19% reduction in the risk of incident diabetes and 23% reduction in the risk of incident diabetes in normoglycemic people. No, we are not talking of pre-diabetes alone. So weight reduction or anti-obesity medications have been shown to give benefit. This is phentermine topiramate data. Again, significant reduction in the risk of developing new onset diabetes. Select study, which is a large CV outcome trial with semaglutide, significant 20% reduction, CVD risk and significant 73% reduction in the risk of developing diabetes. Fine. Jasjeet made it a point that, okay, will you be able to prevent diabetes permanently? And maybe it doesn't happen through lifetime. But okay, this is getting you down to 73%, which is significant. And every year there'll be some, increase in prevalence, but ultimately there'll be a lot of people who will not get diabetes during their lifetime. So there'll be prevention also. Again, liraglutide 3 milligrams. So this is, and then Saptrishi showed you the CV outcome trial with tirzepatide also, the pre-diabetes trial with tirzepatide also. So if you look at the subject, is there a role of newer anti-obesity medications in prevention of diabetes? The answer is possibly yes. Now, will you use in every patient? I don't know. You have to be, finally, it is the judgment of treating physician who has to decide who's the right candidate for right medication. So, judicious use is very important. Then Jasjeet also raised one point about the beta cell dysfunction. Does it reverse or no? So if you look at the further publications from direct trial, what happens is during with obesity and diabetes, there's not all the beta cell are not dying. They are becoming dysfunctional or they are becoming neutral cells in terms of endocrine function. There is de-differentiation towards alpha cell and there is increased apoptosis also. But with weight reduction, unless they have become already the null cells, that means they no more can differentiate. There is reverse differentiation back to the beta cell and there is recovery of beta cell function also. So I think all these things are very important. You heard very good viewpoint from Saptarshi, showing you beautifully the importance of weight in causation of diabetes. Jasjeet made it a fantastic video game, showing different caricatures and taking it on a very, very, hilarious note, how to make a presentation like a very good story. Uh, you have plus points and minus points, and that is where the debates are important. They highlight, they give you the perspective of both sides, and then you take a informed decision. And I have showed you some data from all the weight loss drugs showing that weight reduction with these drugs can help in achieving prevention of diabetes. Second thing is, if you're looking at prevention of diabetes only with lifestyle interventions, the sustaining lifestyle interventions is very difficult. And most of the people regain weight within 2 years, and almost 90% regain within 5 years. So you are back to square one. The beauty of these drugs is they help you sustaining weight loss if you are using them on long-term basis. So that was my, you know, uh, take in nutshell about the anti-obesity medications. If you still have a couple of questions, we can take, because we did a good job in starting early and still have some time.
Yeah,
Yes, Jasjeet and
yeah.
Saptarshi can
So
come here.
before anybody
Any final
asks,
comments? Yeah.
yeah, any other before any question. So I totally agree with you, and that's why the my last slide talked about kind of a consensus, and not even a consensus. It's about a guidance of where anti-obesity medications actually we should have a low threshold of prescribing them. We can't give it to everybody. Obviously, I know that because it was a debate. We had to show a stark difference in between the two. But yeah, if we have these multiple
So
things
you
and
disagreed to disagree. Now you
Before,
agree on that.
I
just a
agreed
minute.
with you.
Before I formally close my presentation, I would also like you to block these two dates, one for the AOCO and one for the ACCD. With that, thank you for your attention.